Thank you very much, Tabata. It's a great pleasure for me to be here today to talk in this ImmunoWebinar. That I think it's a huge scientific initiative, and my talk today is about one of my main lines of research, that is the simplifying antiretroviral HIV therapy. So we'll think that three drugs is always necessary. So my intention is to give to you some the news of the most important topics in the HIV therapy nowadays. Like Tabata introduced me, I am an assistant professor and medical doctor here in UNESP in the city of Botucatu. I'm the head of the infectious disease department and work also as head of the infectious disease service in our general hospital. Also, I am the medical director and I do the supervisor of all the treatment of HIV, hepatitis B and C, and HIV in our institution. I think it's important to mention my function here, because my topic of research is clinical study, our clinical study. So we are gonna discuss mainly clinical issues of the HIV therapy. I work also in the Brazilian Society of Infectious Disease as member of HIV/AIDS Scientific Committee, and in the Ministry of Health Brazil, I work as HIV genotyping expert. And it's important to say that nowadays in the pandemic COVID-19, I do the coordination of all the medical effort here in our hospital. And for this presentation, I have no potential conflicts of interest. And I also want to invite you to know my educational scientific project that belongs to a website, the drbarbosa.org, and have some ramification in the Facebook, in that address, Instagram, and YouTube. You can access a lot of scientific papers that my team produce, and also some media and TV, newspaper, because I think that it's very important to give to the general population scientific information. Well, our summary today is will be start with the basics of the HIV treatment, and the second point is how to individualize some treatment situation, depends on your patient. The third topic is about how you can do the simplification of the antiretroviral treatment, or like some studies like to denomination, the intensification. The last topic is about initial dual therapy for HIV, and at the final, the conclusion. So if we look at the past, trying to understand why nowadays we use 3 drugs for the HIV treatment, we start in the 1987 with the AZT monotherapy. Is the only drug that was available at that time, and the main goal at that time is only to decrease near to 0.5 logs of the viral load of the HIV, and quickly the virus developed resistant for the monotherapy, and the patient start to have the basal viral load. So at that time, we can only reduce a little bit of the viral load and increase not very well the CD4, the lymphocytes. So we can have here only a temporal benefit, like 6 months or 1 year of increase in the life expectancy. Well, after almost 10 years, other drugs were discovered for the treatment of HIV, and the researchers at that time started to compose two drug therapy, like for example AZT plus lamivudine or gidanosine plus lamivudine. And when you put two drugs together, the viral load decrease almost or more than 1 log reduction. But at some time, because in this period, these drugs had not a very strong potency and have some limit about the genetic barrier, and the viral load start to increase again with resistance of related in these two drugs, and all the natural history of HIV started again. So it's here. It's just again a temporal gain, a temporal increase of life expectancy. And finally, at 1994, 1995, a researcher placed in New York started to try to give 3 drugs, because a new class of antiretroviral a new class of antiretroviral drug was discovered. So when you use 3 drugs together, they finally could achieve undetectable viral load below 50 or 40 copies per ml. And when the patient could take the medication for a long time, the viral load maintained in the undetectable level. So the guy that discovered this treatment was Dr. David Hu, placed in New York. He received a lot of recognizing for this discovery, and the paradigm, the message of every patient need to drugs started because this kind of discovery more than 30 years ago. So, like I said to you, the first period during the monotherapy or 2 drug therapies, the main goal is only to increase survival. After the discovery of the protease inhibitor class, we could achieve undetectable viral load, but with a very severe adverse effects. So the patient have to pay a lot to achieve undetectable viral load, because the side effects are very common and very aggressive. So not everybody can take the medication so well to maintain undetectable viral load. The next period after 2004 until 2009, we discovered a lot of other classes and other HIV drugs that could salvage or rescue the patient that failed in this period, the previous period, because here it's very difficult to take the medication because the side effects. And nowadays, finally, we have a very potent, we have a lot of very potent drugs with low potential side effects. So the main goal is the sustained and detectable viral load for a lifetime with very low side effects. That's the reason why undetectable viral load is the main goal in the HIV treatment. What is the benefits of undetectable viral load? Well, the main objective, the more clear of the undetectable viral load, is that undetectable viral load means a very strong reduce in the mortality of the people living with HIV/AIDS that promote increase in the life expectancy. In some papers, in some studies, the life expectancy of a HIV patient is the same of the non-HIV patient, regardless multivariate analysis. Undetectable viral load also means reduce in the morbidities and reduce, of course, the long time cost of the patient. Undetectable viral load means also untransmissible. So a patient that come to my clinic nowadays with HIV, I can say to him, I can say to her that if he could be undetectable, the transmission will not more occur. So it's very important because undetectable viral load can reduce the new case of HIV. It's the main reason why in all the planet in a global analysis we can see a decrease in the incidence of new cases of HIV. Also, undetectable viral load means reducing the HIV chronic inflammation, and it's related to reduce of morbidities and mortalities. And finally, undetectable viral load, it can promote a reduction in the proviral reservoir in the filter, can increase the rate of the cure. I think almost all of you heard about the research of Professor Ricardo Dias that in the last HIV conference present a case of probable remission of HIV, and patient who have a low proviral reservoir can achieve this functional cure more likely than people that not can maintain in a detectable viral load. So is what you call it super undetectable. Every patient that I see, I strongly agree I strongly talk to the patient to how important it is to achieve and maintain undetectable viral load. Well, this is the viral cycle of HIV, and nowadays we have 8 points, 8 ways where we can inhibit the HIV replication. The first one is the attachment between the structure, the proteins of the virus with the CD4. There is a drug that can inhibit this ligation. It's I will show it's a monoclonal antibody. And the second point is the inhibitor of the co-receptor, CCR5 inhibitors. The third point is the fusion inhibitor. In the reverse transcription, we have three classes of drugs: the nucleoside protease, the nucleoside reverse inhibitor, non-nucleoside reverse transcription inhibitor, and a new class of drugs, non-nucleoside translocation inhibitor. So in just one enzyme, we can inhibit, we can have three classes of drugs. The 6th point, the 7th point of inhibition is the integrase, and the last one is the protease inhibitor. This is the table that shows to you the name of the drugs and the class that it belongs. So the first one is the entry inhibitor, mainly mononuclear antibody, ibalizumab, that inhibit the link between CD4 and the viral protein. The second, the inhibitor of the link between the viral protein and CCR5. The name of the drug is maraviroc. We have also the fusion inhibitor, enforvertide. A lot of drugs belongs to this class, a nucleoside reverse transcriptase inhibitor, like old drugs, zidovudine, AZT, lamivudine, and another drug that we use a lot, tenofovir disproxil. We have another class of drug that inhibits the reverse transcriptase, is a non-nucleoside reverse transcriptor inhibitor, like efavirenz, etravirine, nevirapine, and ripivirine. And this is the new class that I told you that was discovered last year. That is the nucleoside reverse transcriptase translocation inhibitor. The name of the drug is islatravir. Islatravir is not available to clinical use, but islatravir is in study in a lot of phase 2 and phase 3 clinical trials with very, very, very good results. And we expect to have this drug in a few years. And also we have the integrase inhibitor like dolutegravir, raltegravir, bictegravir, ilvitegravir, and cabotegravir. That is a drug that you can use in injection. And the last class is the very classic protease inhibitor like atazanavir, darunavir, ritonavir, and tipranavir. So for the treatment of HIV, we have 8 classes, more than 20 drugs available now the world. In some countries we have all of them, like USA and the main countries of Europe, the rich countries of Europe. In Brazil, we have almost all this drug, but in Africa, the options are very limited. Well, you see a lot of drugs, but how to choose the best option to the patient? So we have some guidelines for initial therapy. I want to remember that the classical choice of treatment is the association between 2 drugs, 2 NRTIs, like for example, tenofovir disproxil, lamivudine, or telafenib and entricitabine, or AZT plus 3TC, or AZT plus 3TC, abacavir plus lamivudine. But this is new information. A lot of, or almost all the guidelines allows to initiate the antiretroviral therapy just one nucleoside inhibitor, lamivudine. You can see here the guideline of the International Antiviral Society, the guideline of the Department of Health and Hygiene Service from USA, the European AIDS Clinical Society, the guideline of the World Health Organization, and our guideline from Brazil. All the guidelines include the option, first option or alternative, using just one drug of the class of the NRTIs. And you can see that the other drug, the class of the NRTIs, is also integrase inhibitor or a protease inhibitor. You can see the color green is the main option. Like in Brazil, for example, you use tenofovir plus lamivudine, and dolutegravir is the first option of the treatment, and is the same in the world. Okay, so this is what the guideline says to us. But we know no one size fits all. We have to look carefully to our patient to choose the best drugs. How to choose? We have to look at some drug characteristics like efficacy, safety, genetic barrier, that is how difficult to the HIV develop resistance to the drug. We have to be very careful about transmitted resistance, because a patient that have poor adherence can achieve a lot of bad mutation and put your treatment in failure. The dose frequency is very important. 1 time a day is the best option nowadays. We cannot accept scams. We cannot accept therapy 2 times a day or 3 times a day, because we know that is related to poor adherence. The number of the pill is very important. If you can put all the drug in just 1 pill, it's very easier to the patient take the medication, and also the pill size. So after that, we have to look to the patient factors, mainly the basal, the initial contage, the initial number of the CD4. Patient with low CD4 maybe will benefit with very strong drugs, more potent drugs with more potency. And it's the same for patients with a higher level of viral load. We will see some examples of how these variables can affect the selecting of the treatment. Also, it's very important to have a pre-treatment HIV genotyping, because the transmitted resistance in Brazil, in some places, like for example, efavirenz, 15 to 24% of all the patients before the initiation of the treatment have some fatal mutation for efavirenz. Some characteristic of patient like the HLB 5701 is important to predict hypersensibility to abacavir. We have to look very carefully to comorbidities, like for example, chronic renal failure, liver failure, because some drugs can have toxicity. Also, co-medication, because the drug interaction, it's very common mainly in elderly, in old patient, the polypharmacy with a lot of drugs that can have potential problems related to drug interaction and toxicities. And it's very important to hear the patient and ask to him what you want to take, how is your life, do you know some drugs, do you want to take some drug specific. I like to put the decision in the hand of patient to decide together with him. So this is our Brazilian HIV guideline that I am very proud to belong. And in this guideline, like I say to you, the first option is tenofovir plus lamivudine and dolutegravir. It's 2 pills a day, one time, very easy to take with very low side effects. But for some patients, we can have some problem. If you have some problem with tenofovir, you have to choose other NRTI, like for example, abacavir or unfortunately AZT. If you look to the guideline, if you have some problems with dolutegravir, you have to choose between efavirenz or atazanavir or darunavir. I will show how we do this management. So in the topic, no one size fits all, we have to look very carefully with the main adverse effects in your patient. For example, the biggest problem nowadays is the renal toxicity. So the nephrotoxicity related mainly to tenofovir. Tenofovir, like I said to you, is the first and the biggest option in the class of the NRTIs. We have some problems with the kidney, also with atazanavir. Other bigger problem is the bone demineralization, the osteoporosis and osteopenia related also to tenofovir. So you can see here very clear that tenofovir is a very common drug that can affect also kidney and bone health. Abacavir have some problem with allergic hypersensibility, and this could be fatal. AZT, the first drug, very, very old, with very known problems, like for example, bone marrow toxicity, strong anemia, and lipodystrophy. And problems that we see less common is the central nervous system toxicity related to efavirenz, psychiatric disorders also related to efavirenz. So efavirenz is not a good choice. That's the reason because efavirenz is not in the first place no more nowadays. And the protease inhibitor can induce high cholesterol and triglycerides. And also, all the drugs can have some liver toxicity. And we have to remember always the drug-drug interaction. For my students, for my medical residents, it's obligatory to have in the mobile a app that cross the drugs and show very quickly the drug-drug interaction between all the pharmacy that the patient takes. Well, let's talking about some individualizing situation. I show you here how important is the tenofovir renal toxicity. In the multivariate analysis, tenofovir is the drug that can increase can decrease the estimate glomerular function. So the main concern about tenofovir is the impact in the kidney health. Atazanavir has some similar problem, but atazanavir is not the first line. Tenofovir is the first line here in Brazil. The reason why tenofovir is toxic, it can induce toxicity to the kidney is because tenofovir disproxil, that the drug we have here in Brazil, is nucleoside reverse transcriptase inhibitor, and this drug can reduce the replication of the mitochondria in the proximal tubulus cell. Only here, only in the proximal tubulus cell, tubule cell in the kidney. So this effect can reduce the filtration and decrease so the estimate glomerular rate of filtration. There is other molecule of tenofovir that was developed 5 to 6 years ago. So it's a newer molecule, very close to tenofovir disoproxil. The name is tenofovir alafenamide, and this drug has not a kidney filtration, so it's better, but we don't have in the public market here in Brazil, only in private market. So the biggest problem in terms of HIV treatment toxicity here in Brazil is tenofovir disoproxil related to renal failure. This is one of our work of our service here in Botucatu, UNESP. We tried to obtain the rate of impact of renal failure, and we can show here 13% of all our patients with HIV have some problem with the reduction of the rate of glomerular filtration. So it's very common that our patients have some problem in terms of kidney health. Other problem related to tenofovir is the bone toxicity. So patient can have spontaneous fracture or osteoporosis, osteopenia. So tenofovir disoproxil induce fracture and also osteoporosis, osteopenia, and cannot be used in patients with this comorbidity. Talking about now abacavir toxicity is very aggressive, like you can show here. It's hypersensibility, genetic, immunomediated by this AGLB. We have to do a test, genotyping for the patient, looking for this kind of mutation. And if you have this AGLB, you cannot use abacavir. It's a very expensive test that we have in the public system in Brazil, but it's not so quickly to use. For example, in 1 week, you have to wait 2, 3, or 4 weeks to receive the result. So in practice, we will not use this drug. Also, abacavir is related to increase the risk of myocardial infarction. So some studies suggest that the risk of cardiovascular events are very high with abacavir. So this is a drug that can not be used in patients with hypertension, with high level of cholesterol, for example. AZT, it's an old drug with a very known toxicity, mainly about mitochondrial dysfunction and oxidative stress that can induce apoptosis of the cells and a lot of problems. The main problem is the lipoatrophy, but also hepatotoxicity, anemia, I told you about that, muscle weakness, myalgia. So no guideline in the world put AZT in the first or second or even in the third option. It's just for very specific patient, but I can say to you, we have here in our clinic more than 1,000 patients, and no one is using AZT nowadays. Well, let's talk about let's talk about the main topic, that is the simplification or the intensification that can solve some problems. So if you have toxicity related to the class of the NRTIs, if you have problems with tenofovir, like for example renal or bone toxicity, or with abacavir, with herpes sensibility or increased risk or cardiovascular event, or you cannot, don't want to use AZT because the mitochondrial toxicity, lipodystrophy, you can use the simplification. That is also called like the intensification. What is that? So if you have a patient, a people living with HIV/AIDS that is on drug, that is on antiretroviral treatment with 3 drugs, for example, here in Brazil started with tenofovir, lamivudine, and dolutegravir. And after 9 months, you discover a decrease in the rate of the glomerular filtration. And your patient is undetectable for at least 6 months to 12 months, 1 year. You can just simplify it. You can just cut the NRTI that you have problem. For example, if you use tenofovir plus lamivudine and dolutegravir, you can suspend, you can not prescribe tenofovir and maintain only tenofovir and dolutegravir, 2 drugs. It could be to you very simple, this idea, but for the physician, for the medical staff, it's very hard to forget the idea that the 3 drug is needed. Okay, so the strategy of simplification, we trying to show that it can be very good for some patients that have specific toxicity. You also can do the simplification with lamivudine, with darunavir, ritonavir. Later, I will explain to you why we use darunavir or dolutegravir for do the simplification, or you can use dolutegravir plus darunavir. Okay, so it's very important to say that simplification is not initial dual therapy. Initial dual therapy is other strategy that I will show very briefly in the last of the presentation. Simplification is a situation when your patient is taking 3 drugs, and one of these drugs, mainly the NRTI, have some toxicity, and you have a patient with undetectable overload, you can maintain the patient with only 2 drugs, lamivudine plus darunavir, lamivudine plus dolutegravir, or dolutegravir plus darunavir. Okay, we have a lot of clinical trials, some of them very, very old, from 2014, 2015, and others clinical trial more recent. I will show some of them, but you can see here that the strategy using protease inhibitor plus lamivudine, all these studies showed efficacy in using 2 drugs, comparing 3 drugs. You can do the simplification, like I said, to you with dolutegravir and lamivudine, a lot of study. I will show one of them. You can be more creative and use, for example, other 2 drugs like dolutegravir plus rilpivirine. We don't have rilpivirine in Brazil, or cabotegravir and rilpivirine. This drug, both of them can be used in intramuscular injection. So it's one injection, one time a month in each 30 days. So in the future, you can use 2 drugs to treat HIV, just one shot at month, okay? And also, like I said, you can use 2 drugs, darunavir plus dolutegravir, to do the simplification also. So I will show some selected studies, to each one for example. The dual study is a study published in 2017. Is the most recent simplification strategy with darunavir. You can see here patient that maintain 3 drugs in blue, or patient that goes to the simplification dual therapy, maintain the same level of detectable viral load. If you use different statistical analysis, there is no difference. So you can reduce one potential toxic drug like tenofovir and maintain the same level of undetectable viral load. This is the same strategy with dolutegravir. The most famous and the biggest study is the study Tango. Tango is a study for a very good friend from Argentina, Professor Pedro Caán, that published this study in the Clinical Infectious Disease this year. And the rationale is the same. Patient with 3 drugs, tenofovir, lamivudine, and dolutegravir, versus compared to patient with the simplification of dolutegravir and lamivudine. You can see here the same rate of detectable viral load. There is no difference in terms of efficacy. And the benefit is that patient has not to take the potential toxicity drug. And the last study that I want to show you is the simplification with dolutegravir and darunavir. This is a newer strategy, more recent, published by a group from Italy. The name of the study is Tivista. It's not it's a just single arm study. 130 patients with HIV switched to dolutegravir plus darunavir, mainly because toxicity, like I said, to osteopenia, osteoporosis, lipodystrophy, renal failure, and so on. And after that, almost all of the patient has undetectable viral loads, 76%. Only, and also almost 15% has a very, very low viral load, below 50 copies, that we can assume like undetectable, and a failure is very rare, only 6%. So this is other way to do the simplification. So the reason for simplification, to summarize, the benefits is mitigate the NRTI toxicity, better tolerability, improve adherence, reduce drug-drug interaction, and also can reduce cost. You have to take care. The patient must be undetectable at least 6 to 12 months, and you have to choose between tenofovir plus darunavir, lamivudine plus darunavir, lamivudine plus dolutegravir, or dolutegravir plus darunavir. You have to consider if your patient has or not pre-existing mutation and is not allowed to do monotherapy with any protease inhibitor or dolutegravir, because the monotherapy is related to more rate of failure. Well, this is our study. I have to apologize because I didn't have time to do some images, some graphics to show you. This is our abstract that was accepted to the HIV hepatitis in America that occurred, in fact, not occurred because the pandemic, but let me show you our experience. So we have 59 patients living with HIV/AIDS on antiretroviral therapy, consistently undetectable at the minimum of 6 months, that we have to do the simplification, mostly because toxicity. But I want to show the period. We have 8 years of experience of this strategy in our real-life cohort, from April 2011 to August 2019. So obviously the main point is maintain the undetectable viral load. Okay. So our patient, the main reason for simplification is renal toxicity, 36%, bone toxicity, 24%, or high risk of toxicity or posology convenience, 40%. So we use lamivudine plus darunavir or lamivudine plus dolutegravir, and just one patient had to use darunavir monotherapy because she developed a very rare syndrome with hepatotoxicity to lamivudine also. And we have other patients with dolutegravir plus darunavir. So if you look our results, the per protocol analysis, all the patient was undetectable at least 6 months during the period of during the study period. The oldest patient is that one that I told you about, the darunavir monotherapy, 8 years of undetectable viral load. Intention to treat analysis, we found here 95% of patients with undetectable viral load because we lost the follow-up of 2 patients. Actually, one lost the follow-up, and other, we have one death not related to HIV. So this is a real-life cohort here in our country, and for our acknowledgement is the bigger cohort that we have in Brazil using simplification. We have more patients included nowadays. We next year we will show these results. And the reason why dolutegravir and darunavir is the main drugs used to do the simplification is because these 2 drugs have 2 great qualities. Dolutegravir is the most potent drug of all the antiretroviral therapy option, and also dolutegravir has a very good genetic barrier to resistance. Dolutegravir also is very potent and is the most difficult drug to HIV developed resistance. Has the biggest genetic barrier. So this drug could inhibit very well the virus, and it's very difficult for the virus to develop resistance. That's the reason why use these drugs for the simplification. Well, the last talk is about initial duotherapy for HIV. Just one study, I want to show you the Gemini 1 and 2 that use duotherapy for initial treatment. So patient that is naive, never received antiretroviral yet, and started with dolutegravir plus lamivudine in comparison to dolutegravir plus tenofovir and anthracycline. You can see here the very similar curve of rate of detectable viral load. So for some patient, you can start with 2 drugs instead 3 drugs. But you have to take care about the use of dual therapy. You cannot use if your patient have a very high viral load, up to 500,000. We cannot use with co-infection, with hepatitis B, or if you have a pre-genotyping, a genotyping before the initiation of the treatment, showing some reasons to, for example, lamivudine or dolutegravir. Okay, but for the majority of patients, is a good option that can mitigate the side effects of the NRTIs. So in conclusion, our current goal for the antiretroviral treatment is a long-term undetectable viral load with very low rate of adverse effects. To selecting the drugs, you have to consider aspects of your patient, the virus, and the drugs. To do the combination of the antiretroviral drugs, you have to consider the drug interaction, the adverse effects, the toxicities, the comorbidities of your patient, and the simplification or the de-intensification is a strategy that can mitigate the adverse effect related mainly to the NRTIs, and the initial dual therapy is a promising option for some selected patients. And the main message is that the individualization of the antiretroviral treatment has essential role in the sustainability of the undetectable viral load. I want to thank you for your attention, and remember that you can see this presentation and other scientific material in my social media, Facebook, Instagram, my channel in YouTube, and my website, drbarbosa.org. So I think that now, Tabata, I don't know if you have time for some question.
I think that we can open for question if it's okay by you, Professor Alexandre, and we can open to questions. If anyone has any question, please send in the chat. But I have only one question. You showed some examples of this therapy simplification. And in these examples, it seems that it works, it really works. And why isn't it a reality yet in the treatment of these patients? Dr. Alexandre, can you hear me?
Can you repeat, because the connection is not good.
It's not working very well. Okay, I'll repeat. And about the simplification, the therapy simplification, because you showed some work, some results, good results about this simplification. And my question is, why isn't it used yet, a reality yet in the treatment of HIV patients? Dr. Alexandre?
Tabata.
Yeah.
Tabata, it's possible to you write the question in the chat, because the connection is really very.
Okay, it isn't stable, right?
Yeah, sorry, because I am using the browser Zoom, and the connection for me is very bad. If you can put in the chat, it's my pleasure to try to answer.
Okay, I'm typing. I'm trying to.
Okay, no problem. Why the simplification therapy is not a reality yet? Because because the medical staff is the most conservative people in the world. And we have scientific proofs of that. Physician is the last kind of professional that choose the patterns after a new discovery. So engineers or lawyers, other profession agrees to change the routine very quickly in comparison to physician. So almost all the medical staff thinking about, we have to prescribe three drugs. It's like a mantra in the head of the physician. So that's my mission. I want to show that if you have a patient with sustained virological detectable viral load, you can simplify the therapy, because the residual replication of HIV is very low, and probably to a new mutant HIV virus surge is very low.
Okay, I see. So we need more medical, maybe education. It's more related to medical education, right?
Yeah. That's what I try to do. My fight with this theme is more than 8-9 years.
Oh, I see. A long time. Long time trying.
Yeah.
Okay. So I think that we don't have any more questions, and actually we ran out of time, unfortunately. But if anyone has any question, you can send me, and I'll be happy to send to you, Dr. Alexandre, if that's okay for you.
Yeah, it's perfect.
Okay.
Well, I want to finish it. I want to thank you very much for the invitation and all the questions that you can send to me. That we do like, for example, a live in the Facebook with the answer. So
Okay.
thank you very much for the invitation.
Okay, thank you. Thank you for accepting, and thank you for your talk, and thank you, everyone. See everyone next week. Bye-bye. Bye-bye, guys. Bye-bye, everyone.
Bye-bye.
Bye-bye.